Hello and thank you for taking the time today to review this brief training video. As the title of this video suggests, the content being reviewed involves information regarding the assessment, diagnosis, and management of insomnia in the older adult. Although many primary care providers may overlook symptoms of insomnia in older adults, current research suggests that as many as 65% of adults 65 years of age and older will report symptoms of insomnia. Insomnia in older adults is often compounded by age-related changes, such as an increased number of nocturnal awakenings along with a decline in restorative REM, rapid eye movement, sleep. Additionally, as many as 90% of older adults who experience insomnia have a comorbid health condition that can disrupt the normal sleep cycle. Most patients who develop insomnia seek treatment from their primary care providers. Unfortunately, evidence indicates that most primary care providers lack sufficient knowledge to accurately diagnose and treat this condition. Even though many patients report symptoms of insomnia to their primary care providers, practitioners often focus on the root cause of the problem rather than providing direct treatment for this condition. Further, when a diagnosis of insomnia is made, providers often fail to follow evidence-based practice guidelines for treating the condition. Consequently, training to help increase knowledge of the assessment, diagnosis, and management of insomnia is needed. Based on the background information provided on the previous slide, the goals of this training video are reviewed here. By the completion of this video, viewers should be able to describe 3 or more symptoms of insomnia as experienced by older adults. Explain 3 or more methods for effective diagnosis of insomnia. Apply knowledge of evidence-based practice guidelines to improve the management of insomnia in practice. To help achieve these objectives, this video includes a review of the assessment, diagnosis, and management of insomnia in older adults in primary care practice. Information on assessment includes a review of presenting symptoms, epidemiology, and etiology of insomnia. Information on the diagnosis of insomnia includes a review of the diagnostic criteria for the condition, general considerations for physical exam of the patient, the 3P model, and a review of standardized tools for improving diagnosis. When considering the assessment of insomnia in older adults, it is helpful to examine 3 issues: presenting symptoms, epidemiology, and underlying causes of the condition. These issues are addressed on the next 4 slides. Most patients, regardless of age, will report 1 or more of the following symptoms associated with insomnia: trouble falling asleep, trouble staying asleep, or early morning awakening, along with resultant daytime dysfunction. Daytime dysfunction can take on many forms and can include fatigue, malaise, impairment in attention, concentration or memory, impaired social, family, occupational or academic performance, mood disturbance, irritability, sleepiness, hyperactivity, impulsivity, aggression, reduced motivation, proneness for errors, and concerns about or dissatisfaction with sleep. Aging, in particular, has a direct impact on the sleep cycle, resulting in the symptoms that are frequently reported. One of the most striking differences in the sleep of older patients is their frequent nocturnal awakenings, i.e., sleep fragmentation. Other changes that occur with age include decreases in total sleep, reduced sleep efficiency, time spent asleep as a percentage of time in bed, decreased slow-wave and REM sleep, and a decline in the quality of the 24-hour sleep-wake cycle. Older adults are more likely to have a temporally advanced sleep phase as described as falling asleep early and waking up early. Furthermore, earlier awakening may result in frequent naps during the day, which may further perpetuate nocturnal insomnia. In addition to the inherent biological changes that occur with aging, elderly patients may experience a deterioration of their daily routines that entrain an individual's biological day-night rhythm. Important time markers for the circadian rhythm may erode with aging, such as having no fixed work schedule or irregular meal times, further contributing to sleep difficulty. A closer look at the epidemiology of insomnia in the older adult population provides additional insight that can be helpful for assessing the condition. For instance, evidence indicates that women are twice as likely as men to report symptoms of insomnia. Women are more likely than men to have more severe symptoms of depression, trouble sleeping at night, and excessive daytime sleepiness. Women also have a higher degree of difficulty concentrating and remembering things due to sleepiness or tiredness. Among older adults, initiating sleep appears to be the most prevalent symptom reported, with 65% of this group noting difficulties falling asleep. Additionally, 43% of older adults report early morning waking and 35% report arousal at night with difficulty falling back asleep. Among older adults who report symptoms of insomnia, 25% report napping during the day, which can further disrupt nighttime sleep as well as circadian rhythms. Most adults require between 7 and 9 hours of sleep each night. Older adults should get between 7 and 8 hours of sleep per night. However, due to aging, older adults may only get an average of 5.5 hours of sleep per night. In most older adults that have symptoms of insomnia, the average duration of symptoms before the condition is diagnosed is 1 year. The underlying causes of insomnia among older adults are similar and different from those that disrupt sleep in younger adults. Insomnia at any age can be caused by primary and secondary causes. Primary causes of sleep disruption include stress, travel, poor sleep habits, eating too late in the day, or caffeine, alcohol, and nicotine use. Secondary causes of insomnia include mental health disorders including depression or anxiety, the use of certain medications including those for depression, hypertension, and asthma, chronic medical conditions such as pain, cancer, or diabetes, or the presence of sleep-related disorders such as obstructive sleep apnea or restless leg syndrome. While the information previously reviewed regarding the causes of insomnia are commonly seen in all age groups, in older adults the problem of insomnia is often more complex and multifactorial. Age-related changes can increase symptoms of insomnia, which can be compounded by an increased rate of chronic health conditions and medication use. As individuals age, they are more likely to develop chronic health issues and more likely to use medications that may disrupt sleep. Further, the sleep patterns of older adults are more likely to be disrupted due to a lack of routine. Additionally, the medical system can contribute to the worsening of insomnia in older adults. Current research indicates that most healthcare providers attribute symptoms of insomnia in older adults to other underlying health conditions. Additionally, providers may believe that sleep disturbance in the older adult is a normal part of aging and may therefore fail to address the problem with the patient. If a healthcare provider does suspect the presence of insomnia, oftentimes, providers lack the knowledge needed to provide evidence-based treatment. Various methods for improving the diagnosis of insomnia in older adults are available. On the following slides, a review of some of the tools that can aid in diagnosis are presented. The diagnostic criteria for insomnia require that one of the hallmark symptoms of the condition must be present, i.e., trouble falling asleep, trouble staying asleep, or early morning awakening, and resultant daytime dysfunction. Further, sleep disturbance must occur despite adequate opportunity for sleep in a safe, dark environment, and symptoms must be present at least 3 days per week for at least 3 months. Short-term insomnia or episodic insomnia has the same criteria as chronic insomnia, but lasts for fewer than 3 months. While diagnostic criteria for insomnia once required symptoms to be present outside of any other physical or mental health issue, healthcare providers have come to recognize the importance of treating symptoms of insomnia even if they do occur in the context of comorbid health conditions. General considerations for diagnosing patients who present with symptoms of insomnia should include a thorough physical exam of the patient to acquire a holistic understanding of patient health. Practitioners should acquire a current sleep history for the patient including sleep-wake schedule, bedtime routine, nocturnal behavior, and daytime dysfunction. Additionally, the past medical history of the patient should be reviewed to understand current physical and mental health issues that may be impacting the patient's sleep cycle. A medication review should be conducted to further determine if any current prescribed or over-the-counter medications used by the patient could be disrupting sleep. Medications that may be more likely to disrupt sleep can include antidepressants including SSRIs, certain antihypertensive medications including beta blockers, pain medications including opioids, and OTC allergy medications. Social history of the patient should also be assessed to determine if there are any disruptions in sleep due to work or loss of routine. This data should provide a more complete understanding of the sleep difficulties experienced by the patient. The 3P model can provide practitioners with a more detailed understanding of the patient's insomnia symptoms to help determine the root cause of the problem. The 3Ps stand for predisposing, precipitating, and perpetuating factors. More specifically, the 3Ps involve an exploration of the factors predisposing an individual to insomnia, the factors precipitating an acute episode of insomnia, and the factors perpetuating the insomnia from acute to chronic. Predisposing factors include genetic and personality traits leading to physiologic and cognitive hyperarousal. Precipitating factors are the triggers after which the insomnia cycle begins and are typically stressful events, though they can be positive, ranging from the loss of a loved one to retirement or marriage. Perpetuating factors allow the insomnia to continue, even when the trigger is removed. These factors include behaviors and thought structures that may appear to offer short-term relief yet cause long-term harm, such as increasing time in bed and reducing daytime activity. While the 3P model reviewed on the previous slide can be useful for enhancing a holistic understanding of insomnia in the patient, there are specific diagnostic tools that providers can use to aid in determining if a diagnosis of insomnia for the patient is appropriate. Some of the most common tools are reviewed here and include a sleep diary, actigraphy, polysomnography, and standardized questionnaires. A sleep diary is a form compiled by the patient, usually for at least 2 consecutive weeks, in which the patient notes the time that they went to bed, the time of lights out, time to sleep, time and duration of awakenings overnight, time awake in the morning, time out of bed, naps, perceived duration of sleep, and sometimes quality and depth of sleep. Actigraphy is a device, typically worn on the wrist, that records movement and employs an algorithm to estimate sleep and wake periods. Polysomnography is the gold standard to distinguish sleep from wake. While this tool is not effective for the diagnosis of insomnia, polysomnography can be helpful to rule out other possible explanations for poor sleep, such as sleep apnea or periodic leg movement disorder. Multiple questionnaires are also available including the Epworth Sleepiness Scale, Insomnia Severity Index, and Pittsburgh Sleep Quality Index. When it comes to the management of insomnia in the older adult, it is helpful to separate fact from fiction. As noted early in this presentation, most healthcare providers lack the knowledge needed to treat insomnia effectively. In this section of the presentation, consideration is given to current misconceptions regarding treatment of insomnia and a review of evidence-based practice guidelines that should be used for treating insomnia. Current practices for the management of insomnia in primary care have been extensively reviewed with evidence indicating that actions taken by healthcare providers are often suboptimal. For example, evidence shows that when older adults report difficulties with sleep, only 53% of providers actually record these symptoms in the patient's chart and 39% do not investigate patient reports of insomnia symptoms. If action is taken by the provider to evaluate symptoms of insomnia, the use of standardized assessments is often overlooked, with providers having few tools in place to comprehensively evaluate the patient. Once a diagnosis is made, providers often fail to use any stepped approach to treatment, which has been shown to be effective. Stepped approaches to care utilize the most minimally invasive approaches to treatment first, followed by more aggressive treatment if needed. Treatment for insomnia in older adults typically focuses on the use of sleep hygiene or medication as frontline treatments for insomnia. These trends persist despite the presence of evidence-based practice guidelines to help direct the course of treatment for the patient. Problems with the current practices for the management of insomnia in primary care stem from the fact that medication and sleep hygiene often do not effectively improve long-term outcomes for the patient. Research has consistently demonstrated that sleep hygiene alone is not sufficient to comprehensively address the needs of patients when it comes to reducing insomnia. While sleep hygiene can help identify and address predisposing factors that may impact sleep, this approach does not fully address all of the predisposing or underlying factors that can contribute to insomnia. The use of medications may be effective depending on the specific needs of the patient. However, as a first-line treatment in older adults, medication use must be balanced with concerns over adverse drug interactions or polypharmacy. Further, treatment through either OTC or prescription medications may exacerbate symptoms of insomnia if used over the long term. Evidence-based recommendations for the treatment of insomnia indicate that a stepped approach to treatment is viewed as being important to reduce symptoms and improve patient outcomes. Initial approaches to treatment should include at least one behavioral intervention such as stimulus control therapy or relaxation therapy, or the combination of cognitive therapy, stimulus control therapy, sleep restriction therapy with or without relaxation therapy, otherwise known as cognitive behavioral therapy for insomnia. Behavioral interventions for the treatment of insomnia have been widely supported as the gold standard for reducing patient symptoms. Unfortunately, these interventions are rarely employed as many providers are unaware that behavioral intervention should be used first when providing care for patients with insomnia. While behavioral interventions to treat insomnia should be considered as first-line treatments, evidence-based practice guidelines also indicate that pharmacological management can be considered. However, pharmacological management of insomnia should initially be withheld to determine if it is needed following behavioral intervention. Short-term hypnotic treatment should be supplemented with behavioral and cognitive therapies if needed. When pharmacotherapy is utilized, the choice of a specific pharmacological agent within a class should be directed by symptom pattern, treatment goals, past treatment responses, patient preference, cost, availability of other treatments, comorbid conditions, contraindications, concurrent medication interactions, and side effects. Short intermediate-acting benzodiazepine receptor agonists or Ramelteon should be used first, followed by sedating antidepressants, especially when used in conjunction with treating comorbid depression/anxiety. Examples would include trazodone, amitriptyline, doxepin, and mirtazapine. Other sedating agents including anti-epilepsy medications such as gabapentin or tiagabine and atypical antipsychotics such as quetiapine and olanzapine. OTC medications for sleep or antihistamines should never be recommended. The algorithm included on this slide provides a visual overview of the considerations that should be addressed when managing a patient with insomnia. The algorithm follows the recommendations outlined on the previous two slides and was created by the American Academy of Sleep Medicine. The algorithm can be found online and should be used by all primary care providers when working with patients that have been diagnosed with insomnia. Following this algorithm for the treatment of insomnia should improve the quality of care provided to the patient while also alleviating symptoms of insomnia for the patient and improving patient health and quality of life. Insomnia is a serious health issue that can no longer be ignored by primary care providers. Current evidence-based practice guidelines for the assessment, diagnosis, and treatment of the condition should be effective for enhancing provider knowledge of what is needed to provide care for patients with this condition. It is hoped that this educational video has provided you with a better understanding of what is required to enhance care for patients who present with symptoms of insomnia. Thank you for taking the time to review this video.